some of it will look vaguely familiar because we just started this in lab as well. So when we look at articulations or joints, now keep in mind they're interchangeable. So sometimes your book will say articulations, sometimes it'll say joints. They'll even go back and forth and say like articular capsule 1 minute, and the next sentence is joint capsule. So same scenario. So a joint or articulation, that is a site where two or more bones meet together. Okay. So the job of joints is to, one, hold the skeleton together. That's the difference between the guys in the boxes in labs, the disarticulated skeleton, and the guys on wheels, the articulated skeleton. So it keeps the skeleton together, but it still gives the skeleton mobility. You could fuse all the bones together, keep the bones together, but then you wouldn't be able to move. You wouldn't be able to bend a knee or anything like that. So it's going to keep us together while still allowing us to have mobility. All locomotion movement is caused because we have one bone moving in relationship to another bone around a joint. So that might be getting closer together, further apart, that kind of scenario. Now, joints are the weakest part of the skeleton, right? Most of us have probably jammed a finger or sprained an ankle or something along those lines, where bones, again, fewer of us have actually broken a bone. So they're going to be our weak points. So we have more issues with the joint tissues than we do with the bone tissues. Now, when we look at our joints, of course, we have two different ways we categorize and classify. Because this is science, that's what we do, is categorize and classify everything. So we can classify it based on structure. What tissue do we find there? Do we find cartilage? Do we find dense, irregular connective tissue? Do we find synovial membranes? And then we can classify it functionally. What kind of movements can we look at? Can we move? Can we not move? Can we wiggle a little bit? So starting with that functional classification, so the amount of movement that the joint allows for, so range of motion. And we have three different types of movement capacities. Now, when looking at these terms, some things to kind of get out of the way for housekeeping purposes. Again, anytime you see arthrosis, that has something to do with joints. So like articulations, arts are going to be our joint stuff. Now, isthmus, S-I-S, is single. Isthmus with an E-S-E-S is plural. And ick is usually something to describe. So you can say a diarthrotic joint or diarthrosis. So if you have ick, it usually has the word joint after it. So don't let the spelling bog you down. I'm not going to count off if I'm pointing to the knee and you give me diarthrosis with an E. So I don't care if you plural or single or ick it. Okay. So don't let that freak you out. Some people get bogged down in the details. Okay? So our first group are synarthrosis. So syn meaning together. Okay, so kind of shared. And then arthrosis is joint. So a joint that is stuck together. These guys do not move. So no movement capacity whatsoever. They can be fibrous or cartilaginous, just depending on which joint we are looking at. And because we don't move, we tend to fuse over time. Okay, just like if you have a gate that you never open on your back fence, over time the gate might rust close and you can't open it after that point. So they tend to fuse. They're going to be associated mostly with the axial skeleton because the job of the axial skeleton is to protect. And of course, if you're a joint that doesn't move, you're really good at protecting because you can't be dislocated if you can't move. So they are the strongest of the joints. So very, very protective. Examples, the sutures between the skull bones that we've already looked at in lab, the fusion points between the ossa coxa, so we can fuse those three bones into a single, those are going to be synarthrosis. Amphiarthrosis, again, amphi means both, like amphibian lives both on land and in water. So your amphiarthrosis are your middle guys. They're not immobile, but they're not the most mobile. They wiggle a little bit. They're not the strongest, but they're not the weakest. Okay, so they're kind of the best of both worlds scenario. So they're more flexible than synarthrotic because they can wiggle, but they're not as flexible as diarthrotic. They are stronger than diarthrotic because they're not freely movable. They can just wiggle, but they're not as strong as your synarthrotic, middle guys. So slightly movable. We find a lot of them also in the axial skeleton because, again, the axial skeleton wants to protect, wants to keep things together. Examples, the joints between the vertebrae, the intervertebral discs are going to be amphiarthrotic. They squish a little. So if you pick up something heavy, they can squish to give us a little bit of flexibility. That was one of the questions on the bonus, bone bonus, if you did that one. And then diarthrotic joints, these guys are freely movable. This is what we typically think of. When someone says, name a joint in your body, they're probably going to say the hip or the knee or the elbow. So these guys freely move around. They're going to have the synovial membrane present. So every single diarthrotic joint is a synovial joint. Every single synovial joint is diarthrotic. The difference, obviously, is one is structural, that's synovial joint, and one is functional, that's diarthrotic. So if I was to ask you, what is the functional classification of the knee, you would say diarthrosis. You wouldn't say synovial because that's the structural classification. Okay? So even though every single one is the same as the other, one is describing the tissue, one is describing the movement capacity. So these joints are going to have an articular capsule that is fibrous surrounding and supporting them so they don't separate as easily. So most of them are associated with the appendicular skeleton, the limbs, right? When we think of joints, most of them we're thinking of the ones that are arms and legs and so forth. Structural classification. We're going to name the structural based on the tissue type that we find. So again, they can be fibrous, which would be dense regular connective tissue or dense irregular connective tissue. They can be cartilaginous, so hyaline cartilage or fibrocartilage. Or they can be synovial, the presence of the synovial membrane, which we learned a little bit about on test 1. I know we're trying to block, but we've already mentioned these back in the day. And not only are we looking at the tissues that we have, but we're also looking to see if there's a cavity present. Is there a space within the joint? So the first ones are fibrous. The bones are united by fibrous tissue, dense, regular, or irregular connective tissue. There is no joint cavity, so it's bone, connective tissue, bone, no gaps or anything like that. Most of them are synarthrotic. They don't move, but a few can wiggle. A few are going to be amphiarthrotic. And their major gig is protection of the soft, squishy bits of our body. So the first type we have are sutures. So structurally, sutural or sutures are going to be fibrous joints. Functionally, they are synarthrotic. They do not move, they do not wiggle, because we don't want our skull to wiggle around because then it's not very good at protecting the brain underneath it. So by definition, a suture is where you're going to have wavy articulating bones that interlock with each other, kind of like puzzle pieces to keep them together properly. Now, in between those wavy interlocking bones, we're going to have short connective tissue fibers. So dense, irregular connective tissue. This is a remnant of ossification because, again, all those skull bones, all those flat bones started off as a fiber sheath, dense, irregular connective tissue that fused over time. And this fusion, this ossification never stops. It slows down greatly, but it continues. When we have our fibrous joints, our sutures, because they don't move, because they're synarthrotic, they tend to fuse over time. So if you have somebody who is in their 20s, their sutures are not very close together. You can probably fit a piece of paper between the two sutures very easily. If you have a person in their 40s, they're still going to have connective tissue, but now it's microscopic. You can't put a piece of paper between, but they're much closer. But they're not going to be completely solid. And then by the time you're in your 70s or 80s, you may have entire parts or patches of a suture completely disappear as it ossifies. So when you look at a 70-year-old's coronal suture, they may have patches of solid bone where the frontal and the parietal fuse together, and then patches of still open suture, but it's a very tight suture. So this is one of the things, again, skilled scientists can look at an individual skull, and they can guesstimate the age of that individual skull by just looking at the sutures, those major ones at the top of the head, because you'll have varying widths depending on the age of the individual. And at some point, somebody basically planted the flag and stated sutures are only found in the skull. We don't find them anywhere else, just in the skull. Now, this is actually kind of unfortunate because when they made this comment that sutures are only found in the skull, the ossicoxa, we have those 3 bones that fuse together. They fuse much earlier than your sutures do, so it wasn't really noticeable that they form exactly the same way. So while your ossicoxa is still developing, the ilium ischium are still fusing together, they do have wavy articulating surfaces with connective tissues. The difference is we can't call them sutures. You know, they may look like a duck, they may quack like a duck, but we can't call it a duck. It's a goose. So we can't say the sutures of the ossicoxa because somebody said sutures are only in the skull. So when they finally realized that the ossicoxa fused similar to how the skull fuses just earlier on, they're like, yeah, that's nice. We're still not going to call the joint sutures. So the joints between the ilium, ischium, pubis don't have a proper name because the sutures were kind of selfish and said only skull, even though they look like and they act like a suture. So one of the weird oddities of life. Look at that, it's like a suture. So if we were to go super close up, you would see the connective tissue just kind of making this film in between. So if you look, bless you, closely at skull 14, you might have noticed he had a lot of glue. That's because connective tissue can rot over time. So if you don't glue the skull together, if you leave it alone, it'll eventually fall apart because those connective tissues will break down and disintegrate. It's one of the things that if you do skull mounts, not that you're going to do people skull mounts, hopefully, but if you were to do, a deer skull because you just hunted a deer, you wanted to have a nice skull mount, you have to glue the sutures together because during the cleaning process, it might fall apart. And then you have to put the thing back together like a jigsaw puzzle, which is mildly annoying. So you do have to glue a lot of times because of those joints in between. They can break down. This is just showing you the wavy interlocking isn't just on the top surface that you can see. It actually extends between all contact of the bone. So it's not going to go like straight after that. It's going to keep waving and interweaving like a puzzle piece to keep them together more stable while they're connected. Syndesmosis, that's a fun word. It sounds like you should be ruling Egypt somewhere. Syndesmosis the third. So syn, again, holding together. So this is where a ligament is going to connect. So the ligament is big enough to have a title. Now, some of the ligaments are big, some of the ligaments are small. Now, the size of that ligament is going to determine the wiggle room. Okay, so we do have some wiggles here, so they are amphiarthrotic. If it's a big ligament, like an inch or two long, you might have quite a bit of wiggle. If it's a short, tight ligament, you may have very little wiggle. It's kind of like if you use a rubber band to keep pencils together. If you use a small rubber band, the pencils can't wiggle as much as if you use a bigger rubber band. So the size determines the wiggles, okay, that is allowed. So they are amphiarthrotic. Examples, the distal connection between the tibia and the fibula, so the one we just corrected for in lab. That one is a syndesmosis. And of course, the radius and ulna has lots of connective tissue. That interosseous membrane we didn't have to learn because our bones don't have them. That's a really big syndesmosis. And then we've got a lot of tie downs at the top and the bottom of the radius and the ulna. So here's showing the syndesmotic joints of the radius and ulna and areas around. So the antebrachial interosseous ligament, the palmar radial ulnar ligament, the palmar radial carpal ligament, the palmar radial or ulnar carpal ligament. All those guys are examples of syndesmosis, allowing for a little bit of wiggle room when the bones move around other joints. And here's again our syndesmosis at the end of the tibia and the fibula. So that's again, one of the downsides is like they really need to check their boxes and correct for mistakes there, because that's the ultimate example of a syndesmosis, which is amphiarthrotic, even though they've mislabeled it in the lab book. Agomphosis. It almost sounds like you don't have them anymore when you say them. So agomphosis is a peg and socket joint. Now, this is how your teeth are going to stay attached to your skull. So you've got the peg, that is the root of your tooth, that inserts into the alveolar process of either the maxilla or the mandible. Now, these guys obviously are synarthrotic, right? You don't want your teeth to wiggle when you chew because then it's weird and uncomfortable and it means they're going to fall out. So they're going to be synarthrotic. And they're held in by that periodontal ligament. So unfortunately, this one is a little weird because teeth aren't bones. But as we've mentioned, we don't really have a whole category of ways to describe teeth, their breaks, their connections, and so forth. So we just kind of throw them where we can. So they are synarthrotic, yes, but they don't fuse like the skull sutures would fuse or something along those lines. If these guys fused over time, nobody would ever need dentures because then your teeth would become a part of your jawbone and it would fall out. So these guys, because they're not bone, they can't fuse over time like the other type of synarthrotic joints. And of course, the periodontal ligament, that's that little piece of flesh that keeps the tooth in place. So if your kids are losing their teeth, that's the part that they wiggle and it's disturbing, but it won't let it fall out all the way. Yeah, so gross. That's also something that Nigel asks about when he flies into the window and Finding Nemo. Remember Finding Nemo? And first thing Nigel asked, have they loosened the periodontal ligament? And they're like, no. Dentists love that movie. They actually use accurate dental names and tools and procedures and stuff. They actually do actual science terms with classification and so forth. So that's like the only closely accurate Disney movie ever. Which is really sad because it's about talking fish. How inaccurate can you be? All the other movies are like, wow, somebody didn't read a history book before they made a princess movie, right? Right, like Mulan was a disgrace to the entire country and was beheaded for being a traitor. Oh, no, excuse me. But anyway. Folks, look at it, hold that tooth in place. So there's all those periodontal ligaments holding everybody where it needs to go. So the tooth into the alveolar process. Same thing, just a super simplified picture showing you the periodontal ligament, keeping it in place. Cartilaginous joints, we're going to have cartilage that's holding the bone together. So either hyaline or fibrocartilage, and there's no joint cavity, so bone, cartilage, bone. And they, again, are going to be synarthrotic or amphiarthrotic, little wiggly or no wiggles. So our first one is a synchondrosis, syn holding together, chondro meaning cartilage, so it's cartilage holding it together. Here we're going to have hyaline cartilage, so bone, chunk of hyaline cartilage, bone. These are synarthrotic. They do not move. They do not wiggle at all. They're there to keep a little bit of flexibility for that bone. Okay, so it's kind of like having the sole of a work boot, just a little bit of flexibility when you're stepping, a little bit of cushion, but you're not going to wiggle about. So as we've talked about in lab, we have that costal cartilage of rib 1 and the manubrium held in place tightly so that it's not going to move and wiggle when we breathe in, unlike the other ones, which are actually synovial joints. We also have the epiphyseal cartilage. So when we talked about endochondral ossification, we had the diaphysis that was bone, the epiphysis that was bone, and the epiphyseal plate, the growth plate, that was hyaline cartilage. So by definition, bone connected to another bone by cartilage, that's a joint. So every single long bone while you're still growing has two synchondrotic joints to attach the epiphysis to the diaphysis. This allows the bone to grow in length and gives them a little bit of cushion. Again, this is why kids can do a lot more bouncing around and running around compared to an adult who gets broken easier. Little bit of cushion because we're still growing. Look at that. There's our first rib stuck to the manubrium. Ooh, wow. Symphysis. So with the symphysis, we're going to have the surface of the bone will have articular cartilage, hyaline cartilage, and then we're going to have a fibrocartilage chunk. So it's bone, hyaline cartilage, fibrocartilage, hyaline cartilage, bone. So we have two types of cartilages here. These are amphiarthrotic. They slightly wiggle. That fibrocartilage chunk, again, acts kind of like a sole of a shoe. It squishes a little when you put pressure on it, so it gives a little bit more springiness. So examples, the intervertebral disc. So if you were to power lift 500 pounds, the intervertebral disc would squish a little, but they're not going to allow any kind of shifting or moving of the vertebrae. We also have the pubic symphysis. That's why it's called the pubic symphysis. It's a type of symphyseal joint. So that chunk of fibrocartilage that will allow your pubic bones to wiggle while you're shoving out those big-headed babies. So a nice little wiggle room so you don't have to have a C-section for that case. So there's our intervertebral discs. And there, of course, just under the title, symphysis. So the intervertebral discs along with the pubic symphysis. So a little bit of wiggles associated with it. Bony fusion. As we saw with our synarthrotic joints, our sutures and our synchondrosis, if we are held together and we don't move, we are synarthrotic, we tend to fuse over time, just like the gate that you never open can fuse over time. So you have to be fibrous or cartilaginous because that's how bone forms, right? It's either fibers in the beginning or it's cartilage in the beginning that becomes bone. So we have endochondral and intramembranous ossification happening. And we can't move because if we wiggle even slightly at the microscopic, it prevents those ossification centers from coordinating and fusing. So we have to be synarthrotic and we have to be fibrous or cartilaginous. So that leaves us our sutures that can do this and our synchondrosis that can do this. Now, When we've completed the bony fusion, where we've completely replaced the fibrous tissue or the cartilage tissue with bone, we now have a different description physically. We change the name. So they're now known as a synostosis. This is a fused joint. So example, that epiphyseal line. So every single long bone while you're still growing has the epiphyseal plate, the growth plate, that's cartilage. Once that plate has been completely converted to bone from cartilage, endochondral ossification is done. Each one of those epiphyseal lines is that leftover that has turned from a synchondrotic joint with cartilage present to a synostosis. So take every single long bone in your body, multiply it times 2, and that's how many synostotic joints you have, okay, in your long bones. Now, we can also see it with sutures. The one that is going to happen is that metatopic suture. So we learned the metatopic suture fuses between 5 or 6. So if you're 11, you would still have a dent there. You would still see the suture where the bones have come together. By the time you're 30 or 40, it's a complete solid bone. So we just have one frontal bone instead of that suture being present. So that dent in the bone is now known as a synostosis. It's no longer called the metatopic suture. It is called the synostosis or the metatopic synostosis. So that's one suture compared to all of the long bones and chondroses that move over. Now, if we get really old and we lose a complete suture down the line, so you're 90 and your coronal suture has completely fused, impressive, that one is also now a synostosis. Okay, so when we talk about which one happens more frequently, it's going to be the cartilage converting over. That happens more frequently than the connective tissue. So synchondrotic joints are more frequently turning into synostosis versus a suture, just because of the way the body is set up. Then we have the synovial joints. So this is the rest of the chapter because moving stuff. So synovial joints are freely movable. So every single one is diarthrotic, can move around and hold all that kind of fun stuff. This one we often associated with the limb, so the appendicular skeleton, though we obviously do have some in the axial skeleton. We're talking moving the mouth around, of course we're moving. So you're going to have articulating bones separated by a fluid-filled cavity. And that cavity is what allows for the movement to happen. It's kind of like if you sit on one of those exercise balls instead of a desk chair, you're very mobile. Remember for a while, a lot of people wanted to use those exercise balls as desk chairs. Talk about epic failure in nice work clothes. You sit on the ball, you just roll right off, hit the floor, and try to look graceful, getting up in a skirt and heels. Okay. But that ball allows you to move because there's a cavity there. Same thing here. That cavity allows us to move around. So when we look at our synovial joints, every single synovial joint in the body has 4 characteristics, 4 structures associated with it. It doesn't matter if it's the big boy joints like the hip or the knee, or even the tiny microscopic joints that we find between the ear bones. So those are synovial joints. They have all these structures just like your hip does, except they're much, much tinier. So the first thing we have is articular cartilage. Now, articular cartilage is anatomically hyaline. So if we looked at a slide, it would look just like all the other hyaline cartilage. The articular cartilage is its job title. It's kind of like you're you, and you have all the characteristics of you, but your title in this room is student. So that'd be like identifying you as a student versus as you as a human being. Okay? You can be both, right? But assume you're both. You're all human, hopefully. If you're not, no judging, be an alien, you have better stuff to do. Go probe somebody, right? So anytime we talk about articular cartilage, it's just hyaline cartilage with a jaw for the articulations, for the bones. So they're going to cover the ends of the epiphysis, where the joints are made and the bones come together. Now, the articular cartilage, one of the key factors that affects its functionality and its characteristics is that it does not have perichondrium. So we've learned back in the day on test 1, perichondrium has 2 big functions. What are the 2 big functions of perichondrium? Well, it surrounds the cartilage.
Protects it? No.
That's a third.
Okay.
It kind of protects it.
Provide
Provide nutrients. No blood vessels going to cartilage. So without perichondrium, this articular cartilage has to get nutrients from somewhere else. We have a different person to bring us our nutrients. In this case, it's the synovial fluid. Okay, so that's one big difference between this cartilage and normal cartilage. What's the other function of perichondrium?
Does it take away the friction? Is that was the one? Yeah.
That's just what cartilage does, actually.
Okay.
But what does perichondrium do for cartilage? Brings in nutrients and well, somewhere in the nose, isn't it? You're allergic to cartilage? Perichondrium brings us nutrients and does what?
Cartilage growth.
Okay, cartilage growth and repair. So again, our appositional growth is the only type of repair that is allowed, is available for adults. Now, if we don't have perichondrium, that means we can't repair. So this is why people tend to have joint problems as they age. If you wear away the cartilage can't fix itself because there's no perichondrium to repair. So the next time one of those drug dealers says, hey man, take this pill, it's gonna help fix your cartilage, right? What is that, Osteobiflex, all those pills that you can take over the counter? It says, oh, this will fix your cartilage. This will heal your cartilage. It is a lie. All lies. It is impossible to repair cartilage without surgery because there's no perichondrium associated with your joints. So anytime someone tries to sell you a pill or a supplement and they say it's going to fix the cartilage, it's going to get rid of your arthritis by fixing cartilage. No, it's not possible. It's physically impossible because we don't even have the tissue to repair it. It'd be like someone without teeth going, oh, this is going to help you chew your food better by strengthening your teeth. I don't have teeth. Well, it's still going to strengthen them. Okay? So those pills usually just give you a lot of protein, and in general in your body, if you have protein, you can make tissue. Or you could eat a steak, which is easier to eat than a pill that tries to choke you on the way down, right? That's why you always got to evaluate drug dealers. I know the people at GMC or the Health World or whatever that is down the street, they're like, I'm not a drug dealer. It's like, you provide vitamins in pill forms, drug dealer? Okay. Except you're just not regulated by the FDA like the pharmacists or outlawed like the street dealers. Okay? So anytime you look at those supplements, there's usually little tiny fine print that says this statement is not evaluated by the FDA, which is code for I am lying to make money off of you. So if you want to do it, power to you. Just go in with your eyes open. Don't just think this is going to be perfect. It's going to cure everything. Honestly. Eat steak gives you protein. All right, I'll get off the box. But honestly, those people. Anyway. So no perichondrium. Food has to come from somewhere else. That's going to be the job of the synovial fluid. They can't repair ever. Okay, so if they break, you're going to have problems. You're going to have joint issues. Now, the matrix of this cartilage has more water than other cartilages. Now, it's not like pure water. It's the synovial fluid. It's juicier. It's squishier. Kind of like if you soak bread in milk to make French toast. It's squishier than normal bread because there's fluid in it. Now, it is very smooth because, again, smooth gives us a friction-free environment. So does having a lot of moisture giving us a friction-free environment. That's the reason why you put oil in your car to keep the pistons from seizing up so your car engine can keep moving. Same kind of scenario. Now, the cartilages, even with pressure, they don't touch each other because they're separated by that cavity filled with the fluid. So even if you were to power lift 500 pounds, your knees are the tibia and the femur, the meniscus, aren't going to touch each other. They're still going to be separated, even if it's microscopically, by this cavity filled with this fluid. So as long as that cavity is in place, that fluid is in place, they don't rub on each other, they don't generate friction, they don't damage each other. The joint cavity, separating the big parts, that is going to be filled with our synovial fluid. And then we have the articular capsule, again, sometimes called the joint capsule or joint cap if you're feeling very lazy on typing. So this is the tissue capsule that is around the joint, and it has two layers to it. The outermost layer is dense, irregular connective tissue. So that way the collagen fibers go in all different directions. So if you bend and move the joint, it doesn't tear so easily. The fibrous capsule stabilizes the joint, so it doesn't shift. You don't have to worry about landing wrong and a bubble of fluid shooting out or anything weird like that. It's going to help keep everybody secured and anchored. It is going to fuse to the periosteum of the bone. So the only way to remove the joint capsule from the bone is to cut it off. So again, if you go and you quarter your chicken so you can have chicken thighs and chicken legs, you have to cut through the joint capsules or cook it until they melt. And then they fall apart. The inner layer is the synovial membrane. Again, we learned that back on test 1 with our different types of epithelial membrane. So it's made out of areolar connective tissue, so that loose connective tissue with pockets of adipose and some extra collagen for stability. And it's going to adhere and cover all parts facing the joint cavity. So it's going to cover and adhere to the cartilage. If there's any ligaments on the inside, they're going to be covered. It's just kind of like saran wrap, and you wrap around your food to keep the air out. The saran wrap follows the nooks and crannies and touches all the food in the bowl kind of thing. So, of course, the synovial membrane is going to produce the synovial fluid that we find within the joint cavities. And then finally, the synovial fluid. Okay, so the fourth part of our joints. It is a viscous fluid. Again, viscous means thick. Think of maple syrup. It's my favorite viscous fluid. Okay, so it doesn't pour like water. It kind of plops out. So cold maple syrup or oil in your car. Okay, that's why you don't have water to cool your engine. You have oil. It works better. Now, its job is to reduce friction. So nobody touches each other, rubs on each other, causes issue. And it is mobile because it's a fluid. And as you move around, you're going to squeeze it in and out of the cartilage. It's similar to if you have a pie plate and you put a sponge in the pie plate. If you put some water in, what happens to the water? You have a pie plate or a low bowl, put a sponge in it, put some water in. Where does the water go?
Into the sponge.
It soaks into the sponge. What happens if you press on the sponge?
Push it out.
Water squishes out. Let go of the sponge.
Suck it back in.
Sucks back in. That's what happens every time we move around on our joints. You bend your knee, you straighten your knee, you put weight on your knee. That's going to squish the water out of the cartilage and back into the cartilage, and out of the cartilage and back into the cartilage. So this is going to help lubricate the cartilage and lubricate the joint tissues because it's constantly distributing that fluid all over the place, just like the oil is going all around your engine and your pistons and so forth. So that's going to provide lubrication, friction-free environment. Secondly, nutrient distribution. Since we don't have perichondria, we have to get nutrient oxygen from somewhere. So the synovial fluid is constantly being made and recycled. So you put the synovial fluid out that has nutrients and oxygen, it sucks into the cartilage, drops off oxygen and nutrients. As it pushes away from the cartilage, it pulls away the carbon dioxide, it pulls away the waste. So it can bring the nutrients to the cells, take the waste away from the cells. Now, when we look at this fluid, it's not actually a ton of fluid. It's only about 3 milliliters for most of your joints. So even something big like your knee and hip only have 3 milliliters of fluid. That's 3 drops out of an eyedropper. So not a whole lot, but it's obviously enough to get the job done. It can squish back and forth and do what it needs to do. This is why sometimes your joints pop, right? We've all had joints pop. As you get older, it becomes predictable. It's like we're in the middle of going downstairs. I'm going to sound like Rice Krispies for a few moments, right? Your ankle pops time. Now, some people assume that the joint popping is a bad thing. Okay? We've all heard that, right? Oh, if you pop your joint, you're going to get arthritis. No. What happens when you pop is as that fluid is moving around, dropping off oxygen, picking up carbon dioxide, sometimes those gas molecules collect in a spot and form a bubble. Just like if you put a screensaver on your phone and you start pushing all the little bubbles together and they become one really big bubble, right? I used to use a bath mat analogy, but everyone has screen thingies on their phone just about. Okay. Now, what happens if you had a really big bubble and you push it on the screen? You just push the middle of a huge bubble. What does it do?
It's gonna pop it.
It pops, right? It disperses into a bunch of little bubbles. And you got to collect them all again and try to pop it towards the outside, right? Okay? That's what happens in your joints. The pressure you feel in your joint before it pops It's when you move just a certain way, those gaseous molecules collect in one area. That creates an air bubble within that fluid. You feel the pressure in your soft tissues and you bend it, it pops. And sometimes it's an audible pop that we hear. That's what pops your joints. And it redistributes the gases into that synovial fluid. That's why it feels good to pop your joints. You're redistributing the gas bubbles so they can keep circulating like they're supposed to without causing any kind of pressure. Now, if it hurts when you pop, that means you bent it so much that you started moving or pulling on the ligaments or tendons associated around that joint. And if you have too much pulling on a ligament, it can cause a micro tear. So if you pop and you just hear the noise and it feels better afterwards, you just redistributed the gas in that fluid. If it pops and it stings or hurts, you overdid it. So you push so hard that you moved a ligament or connective tissue on that membrane a little too much, and that causes a little bit of a pain sensation. So popping won't cause arthritis unless it hurts, and that can mean that you're doing micro tears, and then that can lead to issues, just like a sprained ankle just in your joints. Did you have a question?
You answered.
All right. So like in this babbling you were doing, you answered my question. Okay. And then the final job of the synovial fluid is to act as a shock absorber. Okay. When you have canned food, what is in every single canned food or jar of food out there?
Juice.
Juice, right? It's the fluid in your corn. It's the fluid with your peas. It's the fluid with your fruit cocktail. Okay. The reason why we ship things packed in fluid, because fluid is a really good shock absorber. And this is something you could try at home. If you have a jar of olives, I'm only saying jar of olives because you can see through it versus a can. If you have a jar of olives and you shake it vigorously, what happens to the olives? They twist, but nothing happens, right? You can do that at Walmart if you want to. Just, it's probably not the word to say people do at Walmart. So why is she shaking the olives? Okay. If you were to pour out all the liquid, seal it back up, and then shake it vigorously, what's going to happen to those olives? They're going to break. The pimentos or whatever's in the middle of your olives are going to fall out. You'll end up with tamponade. It's just a mess. We pack food in fluid so it can get to location whole. So your corn is corn and not cream corn, right? Your fruit cocktail is fruit cocktail and not applesauce. So by having that fluid, it's going to make sure that it doesn't break in transit. So it acts as a shock absorber. Does the same thing with your joint tissues. When you walk around, it puts stress and strain on your joint. When you jump up and down, it puts more stress and strain. You might notice that if your knees are a little weak, it's like, oh, my knees are sore when I jump too much. Yeah, your fluid's like, what the hell? Stop. Okay? So that fluid acts as that shock absorber, and the more you put stress on it, if you're jumping and running and doing stuff, that's going to generate more stress that your fluid has to deal with, that it has to shock absorb more efficiently. Okay? So lubricating our tissues, providing nutrients to our tissues, since perichondrium isn't there, and then shock absorbing so we don't tear stuff while we're doing jumping jacks, because nobody wants to, do jumping jacks and tear something. So there's just a random joint in the body that has all four of those characteristics, and all synovial joints, hip down to ear joints. We're going to have the joint capsule that has the dense irregular connective tissue on the outside that fuses to the periosteum of the adjacent bones to keep it in place. We're going to have the lining of that joint capsule as the synovial membrane, creating fluid that will fill the joint cavity, allowing to lubricate and shock absorb and provide nutrients. And then we have the articular cartilage to help keep everything from touching each other, because bones touch each other, don't like that, they tend to fuse, and we want to keep things mobile. So all synovial joints have those things. Accessories. Most of us like to have accessories, right? When we leave the house, we have to have a shirt and pants, but most of us like to do something else, like some bling, right? At least a watch. So accessory structures, you're not going to find them in all the joints, but you'll find them in many of the joints to help function. So the first ones we have are ligaments. Ligaments are like your tie-down straps. Okay? So when you're driving down the road and you're carrying boxes and a couch, we usually tie them down so they don't end up on the highway, right? Yep. And the more stuff in the back of your truck, the more ligaments, the more tie-downs you use. Same thing here. Okay, so in areas that are very mobile, areas that are very big, we're going to have a lot of ligaments to help keep everybody tied down, strapped down together. And we have different types of ligaments, just like when you have options to tie down stuff in the back of your pickup truck, You could use a ratchet thing, right? Which are great the first time you use it until somebody wrinkles it and then it gets stuck and then you can't use it anymore. Right? You'll have it move. They get really annoying. Or you can use bungee cords, which could be painful if they hit you. The answer is yes. Or you can have string. That's the cheap version. Just keep wrapping it. Okay? All those do work on tying down stuff, but they have different qualities, different strengths. Same thing with your ligaments. We have different qualities and strengths with those ligaments. The first one we have are accessory ligaments. These are usually the biggest ones. They're the furthest from it. Those collateral ligaments we saw with the knee are accessory ligaments. They're really kind of far out. They're really big, noticeable ligaments. So they help to support, they help to strengthen the joint. Intrinsic or capsular ligaments, interchangeable. These are localized thickening of the joint capsule. So you can't see them from the outside because they're a part of the joint capsule. It's kind of like if you have those specialty work pants that have thick areas around the knees so you don't put a hole in your knees. We've seen work pants like that. Or elbows on work shirts. I saw a pair of work pants where I had it in the crotch. I'm like, I don't know what you're doing with your job, but push it away. But when you look at it, you can't tell the knee patch from the rest of the pants because it's fused to the rest of the pants. But if you were to slice it, you'll find a thick area. Same thing with the intrinsic ligaments. From the outside, it all looks like joint capsule. But if you were to slice through, you would have a really thick area and then a thinner area, that joint capsule. And then we have extrinsic. They're outside of the joint capsule. That's why they're extrinsic versus intrinsic. But they're not as big as the accessories. So they're smaller and usually closer to the joint than the accessory ligaments. So we can have extracapsular on the outside. You can see them from the outside. Or we can have intracapsular on the inside. So you can't see it unless you pop the top. So your anterior cruciate ligament, posterior cruciate ligament that we saw in lab, that one is an intracapsular ligament. It's inside of the joint capsule, securing the knee from the inside, holding it in place. Oh, look at that. It's the knee. So here's your normal. And here we have the intracapsular, your ACL or your PCL. And there's a little extracapsular ligament on the outside. And then this one's not showing the accessories, which would be your collaterals. Pads of fibrocartilage, pads of fat. These are like pillows, right? You can have a couch without pillows just fine. But a lot of times you want pillows for extra cushioning so they can look good, so they can, be shoved in your back. That way you can be comfortable on your couch, right? Yes, we all love pillows on our couches. That's our pads of fibrocartilage and pads of fat. Now with our fat pads, again, it's just not fat floating around in there. That would be chaos, right? When you have a pillow, you just don't throw cotton on your couch. Go look at my pillow. A bunch of cotton. No, right? You put all that cotton inside of a pillowcase. So when you have fat pads, you put all that adipose inside of a synovial membrane. That synovial membrane acts as a pillowcase to keep it all contained together. So just like a throw pillow on your couch, you can use it like packing peanuts. So if we move the joint around, we can put a fat pad there. And if we bend it, we can squish the fat pad, just like if you sit on the couch and sit on the pillow, it squishes the pillow. And then when you stand back up, the pillow poofs back up into place. Okay, so they're going to be able to deal with the changing shape of that joint, filling in the spaces, the gaps created by those joint movements. Pads of fibrocartilage. This is more like either the insoles in your shoe, or you can get those lumbar supports for your work chair. They're not comfortable at all, but they do provide support to your lower back. I know he mistakes them for a throw pillow. It's like, oh, what is that? It's pokey. Oh, it's a lumbar support. So that's fibrocartilage. It's firm, it's supportive, so it's not going to be squishy, but it's going to help keep things stabilized because of that firm support. Examples, the meniscus. The meniscus of the knee, lateral and medial, are pads of fibrocartilage. And they have three different functionalities. One, they subdivide the synovial membrane. Okay? It's kind of like if you have a house that has open concept, right? It's been popular for quite a while, where you have just one big room that's your dining room and your living room. How can you make the distinction? We eat over here and we watch TV over here. You put a couch there, right? Couch facing this way, that's the living room. Back of the couch, that's the dining room. Put a table there, that's the dining room. That subdivides that space. So the meniscus do that. So instead of having one big space in the knee, that divides it into two chambers. That helps with circulation. It also is going to help channel the flow of fluid. right? If you wanted to make sure people didn't walk in front of your couch between you and the TV, what can you do to prevent people from walking in front of your couch in front of you and the TV?
Coffee table.
Put a coffee table. Go ahead, walk through it. Oh, there goes your shins. Okay. You don't want people to pass that area. Put a chair there. This is really helpful if you have kids that like to run through rooms and you want to slow them down. If they don't slow down, you put a chair there. They either fall or they slow down and walk around the chair. Like, oh, now it's an obstacle course. Okay? That's what we do here. When you have that fluid, if that fluid's by the medial meniscus, it can hit that and swoosh over to the lateral side real quick. And then it can get over here and then swoosh back over. So it's going to help direct the flow so it just doesn't go up and down in one spot, because then you're not going to distribute nutrients properly, distribute lubricating properly, and so forth. And then finally, they allow for variations of the shapes of bones. Now, some bones fit together perfectly, right? The trochlear notch and the trochlea fit together perfectly. There's no way they can dislocate. But when you look at something like the knee, those bones don't fit together very well, right? The top of the tibia, what does the top of the tibia look like?
Like a paddle almost.
Yeah, so we would describe that as?
Something.
Just looking at the top of the tibia, how would you say it?
Uh,
You're already overthinking it.
So the cap is the part that sits on top, and it's the, I mean, not technically, but.
All right, picture the tibia in your mind.
Okay, tibia.
What does the top look like?
Flat.
Flat.
Um,
See, y'all were already going too deep. It's like pull back, get some shallow in there. So the top of the tibia is flat. What does the end of the femur look like?
It conforms to the top of the tibia. You know what? Flat.
What's the ends of the femur called?
The epiphysis.
Okay, that's the whole thing.
Oh, I mean, wait.
Now we need to go a little deeper. Like, woman. All right. What do we call the structures at the bottom of the femur? I know. If only you've seen femurs before. What's the bottom look like?
Like knuckles.
Okay, you're getting there. What do we call those structures?
Are they not condyles? No.
They're
yes,
condyles. Condyles are like rocking chairs, right?
Got you. Yes.
Very curvy. If you have a rocking chair on a flat, smooth surface, does it stay in place?
No.
Now, if you get a rocking, you'll move, especially if it's on ice or something. It just wiggles. So if we have the flat tibia, makes it easier for me, and you have a roundy condyle thing, would it be easy to dislocate your knee?
Yes.
It'd slide right off. So what we do is we put a meniscus there. The meniscus sits on the tibia. It's flat on the bottom to sit on top of the tibia, and the meniscus is curved on top. That's what meniscus means. It's the curve that we see with fluid in chemistry land. You'll use that word in chemistry land. But it's curved. So flat on the bottom for the flat tibia, curved on top for the curved femur to sit in. So as long as you've got that meniscus, you're not going to separate the femur from the tibia.
So
It's like if you had a rocking chair and you put grooves in the ground so you could only rock in one spot. You couldn't slide to the side or anywhere else. Right? So that allows for those differences in shape so we don't dislocate.
kind of like a golf tee for a golf ball. Golf ball sits on the golf tee. So
Yeah.
it doesn't, okay.
Or those little, what are they, chucks for your RV to keep your wheels from rolling?
Yep.
They're wedge shaped to keep them in place. It's like two chucks.
Okay.
So if you just do this. Okay. If you drive around in RVs, rest of us cheap people, we just use a block of wood or cinder block or something. So that's what our fiber cartilage pads do. They allow for variation in the shapes of the bones. They allow for channeling of the flow of fluid, and they subdivide the synovial membrane. So if we look at our knee joint, there's that flat-headed tibia. There's that curved-in femur. So they would just rock on off if we didn't have that meniscus there. So here we can see the meniscus. It's flat here, and it's curved to accommodate those changes in shapes. And of course, it's going to subdivide that big cavity into two smaller cavities and help channel the flow. So again, that synovial fluid can flow back and forth, generating better shock absorbing and nutrient distribution and lubricating than it would be able to do otherwise. Tendons. Now, tendons are not officially a part of the joint because they are just muscle to bone, but they happen to hang around the joints. And because they happen to hang around, they help to stabilize those joints. It's kind of like if you have a bed, right? I know analogies. When you have a mattress, what keeps your box spring and your mattresses together?
The frame?
The frame. Can you sleep on a bed without a frame?
Sure.
Yeah, what happens over time with the mattresses?
They just get squished.
Squished, and do they stay perfectly on top of each other?
No.
They scoot, they slide. If you have a really cheap bed frame and it's just the bottom frame and not the top, you're always trying to reposition the mattress back onto the box frame. Does anybody else do that little thing every now and then? Get back on. Okay. If you have a good bed frame, goes all the way up, that doesn't happen. Or if you put your bed next to the wall, does the mattress shift anymore?
No.
No, it's the wall. Is the wall a part of your bed?
No.
No. Right? If you have nightstands on either side, does that help stabilize your mattress?
Sure.
Is that a part of your bed?
No.
No, it's your nightstands. But because the wall is there, it stabilizes your bed. Because the nightstands are there, it stabilizes your bed. They're not your bed, but they provide stability. That's what tendons do. They're not a part of the joint, but they happen to be there. So they physically block too much movement. A great example is the shoulder joint. Okay, you have the deltoid. The deltoid sits right on top. It's going to attach to the deltoid tuberosity. Okay, it is darn near impossible to dislocate your shoulder straight up, because if that shoulder tries to go straight up, there's a big deltoid sitting right there strapped down. So you can't dislocate straight up without tearing the deltoid because he's big, bold, and blocking your way. Okay, that's the wall in your house. So just because it's there, it stabilizes the joint, but the deltoid is not a part of the joint itself. It's just hanging out there. So that's how tendons work. They help to support, they help to limit the range of motion like a wall, like a nightstand, but they are not a part of the official joint tissue. So a lot of the shoulder joint is supported by muscles and the tendons of those muscles, keeping them in place. Okay, and that's just the knee picture. I don't have the picture of the shoulder. Bursas or tendon sheaths. So a bursa is just a pillow of synovial fluid. So a fat pad is kind of like a normal pillow with a pillowcase in cotton. The synovial membrane pillow, the bursa, would be like a pillowcase filled with those little styrofoam balls that make it a bean bag. They're very comfy pillows until they rupture, and then those things get everywhere. Oh, okay. That's what a bursa is. It's like a bean bag chair. It's still cushiony, it's still pillowy, but it feels different and it acts a little different because the stuffing is different. So in this case, it's just a liquid pillow. So it just has synovial fluid on the inside. And we'll see them in different spots within the joints to prevent friction or stress between ligaments or between a tendon and other structures around it or within the joint itself. A tendon sheath is just an elongated bursa that wraps around a tendon, like a hot dog bun around a wiener, right? When you eat a chili dog, you hold onto the bun because the chili is too messy, right? You don't poke the chili with your finger while you're eating. And hopefully, if you hold the bun secure enough, when you bite into the chili dog, the wiener doesn't shoot out across the room, right? Yeah, see, now I've ruined eating chili dogs for you. I want you to be like, this is like my tendon sheath and my tendon... Right? It doesn't move. It's going to protect it. So that's all a tendon sheath is a really long bursa wrapping around a tendon. So here's some bursa and tendon sheaths. Again, they're colored green for your viewing pleasure. They're not really green in the body. But they're going to act as little pillows, little packing peanuts around those tendons coming through. And this is essentially showing you how they would fix carpal tunnel syndrome. So if you remember carpal tunnel syndrome, you get irritation of the bursa right around in here, and we build up too much fluid. Your pillows get overpacked, and now you can't move properly. So in severe cases, they will cut through this retinacula here to open that up so you can have some swelling without limiting your range of motion or tingling numbness in your fingers. So that's why you get carpal tunnel syndrome. These guys get irritated and swell. Here's showing you tendon sheaths. There's not a lot of cushion in your fingers, right? It's skin, fat, tendon, bone, skin, fat. So we are going to wrap around those big old tendons coming from all the way up here, so there's not a lot of friction going on in our fingers. That was the hump. Woo, now it's downhill. Most people like downhill. So our types of synovial joints, you probably already know about these. You might have already learned about these back in, elementary school or middle school. So our different types of joints, we have plane joints and gliding joints. They're the same thing, just different descriptives. Hinge joints, pivot joints, ipsiloidal or condyloidal joints. Ipsiloid is a fancy way to say oval. So they move in an ipsiloid manner. Condyloid is going to refer to the structures, condyles working together. Saddle joints and ball and socket joints. And there's a picture. This is the one that was in your previous lab book. Now it's updated to a different picture, but you can find something similar to this one in your textbook, showing you the different types of joints and what they would look like. So our first ones are plane joints. Plane joints, the articulating surfaces are flat, and they allow for a slipping or gliding motion. They got their name from the wood plane tool. So if you've worked with wood, wood planes are a box tool that you move across the surface of wood, and it makes the wood curl, and it makes it smooth and flat. Okay? Same thing that makes chocolate curls and cheese curls in the kitchen. There's a little tool that moves across, and it cuts little planes of lovely, delicious chocolate curls. Right? In this case, not so delicious. So they just slide back and forth. So you have a facet that moves back and forth around each other. Where do we find these? The wrists, right? Those guys are kind of boxy looking bones. The ankles, right? They're all cube shaped. They slide around each other. And then the vertebral processes. So again, you have the superior articulating facet that hooks up with the inferior articulating facet. You touch your toes, they slide past each other. You stand up, they slide back. Okay? So that's going to be a plane joint. Hinge joint, get this, it works like a hinge. Again, we would all be doctors if life was this easy. So a rounded condyle that fits into a curved fossa. So you're rocking in one little area. So the motion is like a door hinge. Typically, we have flexion and extension only. So the classic, the elbows can flex, the elbows can extend. That's all they can do, back and forth. So the elbow joint's a big one. The crenon fossa, or the trochlea is going to fit in the trochlear notch. And we hook into the olecranon fossa in the back or the coronoid fossa in the front, keeping us in line. The knee, condyles of the femur rocking on the tibia, and the jaw, you've got the mandibular condyle rocking in the mandibular fossa of the temporal bone. Now, the jaw and the knee are sometimes referred to as modified because they're kind of jankety. The condyle is much smaller than the fossa, so it can rock around in there. It's kind of like if you have an older gate, originally gates just open and close, right? But if you got a jankety one, sometimes you have to lift it over a rock or lift it up to put the lock onto it, and then it kind of shimmies as you move it around. We've all seen jankety gates. And you just like lift it over, move it over. That's a little bit too much wallowed out when we look at the hinges. Same thing here. If you have more movement, you can do more, right? With your jaw, you just don't open and close it. You chew like a cow because we have a jankety joint there. Rocks around in that fossa. Pivot joints work like basketball drills when you used to have to do pivot. Remember pivot drills? I think I remember pivot drills junior high. It's been a while, but you like into a sleeve-like thing of bone. Oftentimes the sleeve-like thing has a title. So example, the ontanoid process is going to fit into the sleeve-like region of the atlas. So the atlas can pivot on the axis so your head can go side to side. So that's a pivot joint. Condyloidal or ipsiloidal. So these are the knuckles. So when you look at the metacarpals, the top of the metacarpals are rounded in a condyle. When you look at the proximal phalanx, they're rounded in a condyle, so they can rotate around each other. So they're allowing all angular motion. So you can do flexion and extension. You could do abduction and adduction. You can go whoop-de-doo, Basil, right? Make circles with your fingers because of those condylar joints. Now, unfortunately, abduction, adduction, you do have to spell them correctly because there's only one letter difference, and the one letter makes them the opposites of each other. So the spelling would count. I can't get around that one. Okay. So again, between the wrists and the fingers, allowing for the movement and the twirling of your fingers. Saddle joint or solaris joint. Solaris is just Latin for saddle. So these are rare. We've got two of them. Okay. So each articular surface has a concave and a convex, and they fit into a concave convex on the other bony structure. So the carpometacarpal joint of the thumb. So between the trapezium and the metacarpal, you got these little dents that work together. This allows you to twiddle your thumbs. Your thumb is opposable because of this saddle joint. And you can remember saddle joint and twiddling both independently, so they work together. So that's how you can twiddle your thumbs, is because you've got a saddle joint. Then you've got a ball and socket joint. Get this, a ball fits into a socket. It's amazing. All right, so you have the rounded head of one bone fitting into the socket associated with the other. This is the most freely of the movable joints because you can go in any direction. If you've watched the Dyson ball vacuum commercial, you know all about ball and socket joints, right? He gets all uppity about his vacuum, about how it's so superior to normal vacuums because it can turn and curve. You're like, wow, you watched somebody's hip move and just copied it in vacuum and claimed your vacuum god over there. But that's how the Dyson ball is so mobile. It uses a ball and socket joint between the head of the vacuum and the body of the vacuum. So our shoulder, the head of the humerus, very round, fitting into the glenoid cavity of the scapula. Our hip joint, the head of the femur, fitting into the acetabulum of the ossicoccyx. Stability. When something moves a lot, we need to talk about something to stabilize it, because if you move too much, you could dislocate, and that could be a bad thing. So we have to have some elements to help stabilize that joints that allow for movement, but make sure we don't move so much that we break apart. Okay? So we have three different features that help with that. We have articulating surfaces, we have ligaments, and we have muscle tone. Okay? So the first one is articulating surfaces. Ball and socket joints are the most stable because they have a lot more articulating surfaces, right? If you want to make sure you don't lose your kid at Walmart, you hold their hand, right? And if they don't want to hold your hand, you get a child leash. They're adorable. My kids had one that was a Mickey Mouse backpack and his tail hooked to you. It's not like he was on a choker chain, so get back in here. Though that would have been wonderful. Okay, but anywho, keep your dog on a leash, keep your kid on a leash. Lots of surfaces that you touch, you're not going to separate or have any problems. If you don't have kids, don't have them. You got to feed them and water them. But think of a truck, right? Whenever you're carrying stuff in the back of the pickup truck, what do you want to make sure you do so stuff doesn't fall out?
Tie it down.
Okay, we tie it down. What else do we want to do so stuff doesn't fall out? To close the tailgate. Because if it's not articulating at the back, it'll just fall right on out. Okay? Flatbed pickup trucks. They don't have any articulations, right? No sides. So stuff can fall off of them very easily. And so if you want to make a van, you don't worry about losing anything out of a van because of all the articulating surfaces, the sides, the back, the top, everything, right? That's why you kidnap kids in vans and not in trucks. You don't kidnap kids, but you can't get out of a van as easy as you can a truck, right? Right. You just jump, you're out of a truck, right? I know. 80s kids did that a lot more than today's kids, right? Today's kids are like emotional or something. Going up to elementary school, we had that one parent who had the pickup truck. We were all in the back because it was the 80s, nobody cared. And school was, all right, I'm going down to 5 miles. You better bail now. So it was like, we all jumped out of the pickup truck to go to school. Bounced, rolled, kept going. Nowadays, they're like, my feelings got hurt because I landed weird. Fluffy kids. Ride in the back of a pickup truck, they'll give you character. Or bruises. Mental scarring. It's fine. It'll be okay. So, articulating surfaces keep you together. If you don't have articulating surfaces, you're going to rely on ligaments. You have a flatbed pickup, you're going to strap down everything within an inch of its life. More straps, more straps, more straps, right? If your tailgate's missing, you have to use more straps than if your tailgate goes up. And you obviously use more straps in a pickup than you would in the van. So if you don't have the articulating surfaces, you're going to replace it by having those ligaments, those tie-down straps. So you're going to need those. So if our other stabilizing factors are inadequate, it could lead to tension and problems with those ligaments. Okay? That's usually why they tear, because you weren't stabilizing like you were supposed to. You either